1440 KVON 99.3 The Vine. Good morning, it's Bob, and I am joined with my very special guest, Dr. Stuart Allen. Good morning, Dr. Stuart.
Good morning, Bob.
How are you today?
Doing great.
Well, we've been waiting to get you in here because we're going to talk about cardiovascular health, and you are the new expert in town, aren't you?
I am. Thanks for the invitation.
Oh, you're quite welcome. It's good to have you here, and it's a good timing for me to learn more about taking care of my heart.
Yeah, it's better timing than I realized. On the way in, I saw a plume of smoke coming from behind the radio van. I see Bob back there smoking
Mr.
right
Bobby,
before
there's no
the
smoke in
cardiovascular segment. So
Listen,
we have a little more to talk about today than I realized.
I guess we do. There's this, I won't even try and justify it, but Marlene and I do this smoke thing that it's a jungle thing. I can't justify it, especially to you, and I swear I knew you were pulling in. I'm on, Marlene, the doctor coming in is going to give me crap. It's our thing. It's our ritual. I'm okay, we'll do our ritual, but watch. And then you came walking around the van and went,
right.
What are you doing? Getting busted?
Mm-hmm.
Uh-huh.
Yeah, we'll talk about that later.
Okay, thank you. So where shall we begin? What is cardiovascular disease? Let's just take off there.
Okay, so big picture. So cardiovascular disease is really a catchphrase for any disorder or abnormality that involves the heart. That includes the arteries that take blood to the heart muscle, the valves in the heart, and really any vessels anywhere else in the body. Vessels that take blood to the brain, to the legs, to the arms. Any disease of those vessels is really considered part of cardiovascular disease. Now, a subset of cardiovascular disease is coronary heart disease. Okay, that specifically refers to disease of the arteries that take blood to the heart muscle.
Okay. All right. So this is a loaded question. Who's at risk for CV?
Well, Bobby, you're at risk.
Thank you. I knew that was coming.
Anyone is really potentially at risk, and physicians can help determine your level of risk by looking at what we call traditional risk factors.
Right.
These include your age. Do you have high blood pressure? Do you use tobacco? Do you have diabetes, high cholesterol? Do you have a family history of premature coronary disease in a first-degree relative? So we kind of look at all of these traditional risk factors to determine each individual's level of risk.
Okay. Well, on a personal level, I can still run 45 on the elliptical and swim for an hour straight.
That's
So
good.
am I getting rid of that one proverbial per day trying to kick, but we're still smoking one? Is that one still going to kill me?
One cigarette a day does make a difference. Okay.
Man,
But
no justification up in here.
But if you are exercising 45 minutes a day, that is a good thing.
Well, hour and 45. I do 45 on the elliptical, and then I swim an hour. I swim a lot.
No, that's a great thing.
So I'm okay, good. I'll try and get that one out. Next time I see you, hopefully I'll go, okay, the one is gone. There it is. All right, let's move on. So what are our symptoms? How do we look for it? How do we know if we should be checked? Shouldn't we all be checked?
So we should all be checked. You know, the classic symptoms of heart disease, people think of chest pain. But it's really a lot more than that. I prefer to use the word chest discomfort. Some patients describe it as a heaviness or a tightness. Others use the word indigestion to describe it. It's a discomfort that can sometimes radiate to one arm or both arms. It can go up your jaw, to your back. Sometimes you get short of breath with it, nauseous or sweaty. So it's really a myriad of things that someone can experience. But usually heart disease has some sort of chest discomfort component to it.
Okay, so that's the thing that we can find. Now, what's the best thing for prevention besides taking care of your lungs?
Right. So, prevention is very important, perhaps the most important. Cardiovascular disease remains the leading cause of death in the United States in both men and women, far outpacing any form of cancer. They say that there's one death every 39 seconds from cardiovascular disease, and then it's responsible for about a third of all the deaths. Okay.
A third of all deaths have to do with your heart.
Have to do with your, the cardiovascular system in general. So that's really including the heart and the brain. And the medical community has been doing a really nice job over the past 10 to 15 years in treating some of these risk factors that we look at. Blood pressure is lower than it used to be. Cholesterol levels are lower. Fewer people are smoking. And all of that put together has actually caused fewer people to be dying from coronary disease today than they were 10 years ago. So that's exciting. We're all optimistic that will continue, but there are some problems that are still present. Obesity and diabetes continue to be on the rise.
Right.
Okay. About 30% of American adults are obese. What's even more sobering is that if you look at kids ages 2 through 19, about 30% of them are either overweight or obese. Okay, so that's a real sobering thing. And in addition to that, the population is getting older. Okay, so the baby boomer generation is getting older. In 10 years, we're going to have more elderly people than we do now. So that means more coronary disease.
Right.
So with people getting older, obesity on the rise, we really have to address this issue.
So it's don't smoke, eat the right foods, exercise. These are all the good things.
These are all the good things, and it's a great point because despite the things that doctors can do with medications, probably the most important point here is that it's what each patient can do at home by himself. And
Prevention.
Prevention. Oftentimes, that is more important than actually, preventing heart disease with medications. So we're talking about a well-balanced diet, low in saturated fat. Exercise 30 minutes a day, and that can be 15 minutes in the morning, 15 minutes in the evening. Okay? Not using tobacco products, not drinking too heavily. You put all those things together and you decrease your risk for developing heart disease later on in life.
I don't drink a drop.
Good for you.
I just want to score some points there.
All right.
I don't drink a drop. I drink a lot of water, 8 bottles a day.
Water's
I'm
good.
big on water. Water
Water's good for
flushes
you.
the
Water's
system.
good. Salt's bad.
All right, but what about younger people, like people in their 20s and 30s? Should they be concerned? Should they start getting checked early? How early do we get on this?
Yeah, so that's when it should really start. How early should we get on it? Parents should be thinking about their children. Are their children exercising the amount that they should be?
Right.
Are they eating the right types of foods? And when you look at patients or people in their 20s and 30s, there are good studies that show if you develop risk factors that early, that increases your risk for developing heart disease later on in life. So we really, really need to be starting early.
Have you seen this Honey Boo Boo thing? Does it just disturb you beyond belief? Do you know what this is? It's a small child who's really big, and they just keep feeding her. It's a show. You've seen it?
I've not seen that.
It's horrible. It's a horrible show, isn't it? They justify this baby, and she's plump. She's what you would call obese, and they just keep feeding her. And she's cute. She has beauty pageants.
Oh, wow.
And I'm thinking that's going to be a sick child, isn't it? I mean,
absolutely.
She's twice her normal what the weight she should be, probably.
Absolutely. I mean, thinking about 30% of kids being overweight or obese, and it's really for two reasons. One, they're eating more than they used to, and they're eating higher fat content.
They're eating the chips and stuff.
Chips,
and then I think
fast
PE isn't really as big a deal as it was when we were kids.
It's absolutely not. I mean, they've surveyed high schoolers, grade 9 through 12.
Right.
And they said in the past week, how many of you have done 60 minutes of continuous physical activity? And about 30% of kids said that they had not. And that's a lot worse than it was, 10, 15 years ago.
Right. I mean, it was sort of mandatory. I remember running the track was part of the deal. Before, you start PE, you go, okay, run the track twice, and then you get off to whatever you're doing. So exercise is key.
Exercise is key, yes.
All right. So let's get to the new stuff, because you're the new guy on the block with all the new tricks, right? So innovations in treatments?
Innovations, yeah. We prefer not to call them tricks. But
Oh, not tricks, sorry. Innovations. Yeah, I know. You went to school for probably 15 years to get here. So
that's right. So, cardiology's been really fortunate in the past 10 years to have a lot of innovations. And there are a few main areas. One is in medications. Some of the medications we use to help prevent coronary disease, in other words, the medicines we use to treat cholesterol, treat high blood pressure. There have been these new medications that have really done a great job at doing those things. We also have had innovations in some of the devices that we use. We have better stents now to treat coronary disease. When we fix blockages in patients' arteries, we now put in coated stents most of the time that do a better job at keeping that artery open.
Right.
So we've been lucky to have these developments. And we've also had some developments in the approaches to certain procedures that we do.
Now, don't some of the stents actually have, drugs in them somehow?
Right. So, when heart catheterizations, which we can talk about, first started, and let me just take a step back and tell you a little bit about what a heart catheterization is. It's a procedure that we as cardiologists do to find out if there are actual blockages in the arteries that supply your heart muscle with blood.
Right.
When there are blockages, that's what can cause chest discomfort. That's what can cause heart attacks. So we go in through an artery either in the groin, called the femoral artery, or an artery in the wrist, called the radial artery, and we use catheters and wires to go up to the heart. Then we inject contrast into those arteries that we're interested in.
Like ink dye.
Yeah.
Right, so you can see it on the camera.
Right, and then we take x-ray pictures of it, and we look at the x-rays, and we can see if and where there are blockages. Okay.
So you can literally see where it slows down, where it gets
Where it
stuck,
narrows.
where it narrows, and that's
And
what we're
sometimes
looking
slows
for.
down, but mainly
And
where it
narrowing is cholesterol?
narrowing is plaque buildup, and a lot of that is cholesterol.
Okay.
That's
All
right. So once we see that, if there are blockages that we can get to easily. Oftentimes we can put in stents, these round metal devices that open up inside the artery and stay in there permanently.
Right. I've saw my mom got some of those. They're like a little chicken wire that opens up.
That's right. That's right.
It's like a chicken wire tube that's really tiny, and it opens up once you put it inside, and that holds that thing open.
That's right. Except they don't use chicken wire.
It's not chicken wire. That was my layman's terms right there.
Right. So you're asking about the coatings. One of the developments that we've had is that they used to just use bare metal stents. And the problem with using just bare metal stents to open up the blockages is that in a relatively high percentage of patients, the blockages come back. So now we have medicines that come on the stents that prevent those blockages from coming back as much.
Aha! So that is that part. So it's drug coated, and they're not metal.
They are metal.
They're still metal,
and they're drug coated.
And they're drug coated.
Yes.
See, that's where my chicken wire thing came in. That's the metal part.
A good analogy.
The little, you know.
No, that's a great analogy.
In layman's words, I was watching when they were doing my mom's going, this is wild. The science, as far as you've taken it now.
That's incredible.
So tell me the difference between, because I know the groin one, my buddy George had that one. He didn't like it very much, but it was necessary. But this new wrist one, isn't that a lot less invasive? It's not as uncomfortable kind of thing?
So it's still invasive, but it is more comfortable. The wrist approach, or the radial approach, has really been around for a number of years. And in some European countries, it's the predominant way in which they do the procedure. We're a little slower to catch on here. And there are certain cases where the femoral approach is the way to go. But about 10% nationally now, the approach is radial. Okay, and that is on the rise. And the reason is a couple-fold. Number one, the bleeding complications are lower when you go through the radial artery.
Okay.
And number two, patients prefer it more. You know, in cardiology, we do these big randomized control trials to figure out what's the best thing to do, what's the best approach to treatment. And recently there was a trial called the RIVAL study, and it took about 7,000 patients, and it split them up. Half the patients had the procedure done through the femoral artery, and half had it done through the radial artery. Then at the end of the procedure, they asked each patient, if you had to have this again, would you want it the same way you had it the first time?
Right.
So in patients who had it done through the femoral artery initially, about half said, I prefer to do this through the femoral artery next time again. When you look at the patients who had it through the radial artery, about 90% said that is the way they would want to have it done the next time if they needed the procedure. So patients really prefer it. It's more comfortable. They can get up and walk around easier afterwards.
Mm-hmm.
And then, of course, there's the lower bleeding complication rate.
Right. Is it more of a straight shot though on the groin than it is on the wrist? It seems like you have a straighter shot to get to the heart, and you got to curve around some corners if you're going through the wrist.
You have to curve both ways. The wrist approach is less of a straight shot, so it's harder to do. So I think to get good at it, you have to do a lot of them. But once you have that not mastered, because there are very few people who have actually mastered the technique, but once you are proficient at it, I think it's an ideal way to do it.
So you would prefer
I would prefer it. And again, there are certain situations with very complex disease. You know, if patients have a lot of blockages and a lot of calcium in the arteries, and you think it's going to be a difficult procedure, in that situation you would do it through the femoral because it is easier.
Kind of a straighter shot.
Straighter shot. But for my patients, the majority of them, I would prefer using the radial approach.
You know, you have your eyes glow. You don't smoke, drink. You probably work out an hour a day. Why? Your eyes are shiny. You're a very healthy man.
It's the cold air.
Is it the cold air?
It's the cold air.
Yeah, way to knock that one off. I'm just saying. All right. So on a personal level, as you know, because we spoke yesterday and we've talked, I lost my drummer, and a lot of us in the community lost, an upstanding, beautiful man with a huge heart. And it turns out he had a huge heart. His heart was 50% larger. This is my drummer, Jim Lang, and friend to everybody in the community. Yes. We had no idea. He had a couple of surgeries, oral surgeries, where they checked his blood pressure and said, no, you're fine for surgery, because you need to know this. And then, I've heard it's called the silent killer. How do we manage to find out? Is there tests we should be taking? And so apparently, according to the coroner, it was hypertension, enlarged heart. That's what we got back. What do we do to avoid that? What do we need to do?
Yeah, so it has been called the silent killer, and I really think that's because we're probably not listening closely enough.
That's what I'm looking for.
On the outside, a lot of people look normal, but a lot of times it's what's going on the inside, and that's why it's so important to see a physician on a relatively regular basis, even in your youth. Okay?
Right.
What you're describing with an enlarged heart is what as physicians we refer to as cardiomegaly. It just means big heart.
Big heart.
Okay. And that happens for a lot of reasons. Coronary disease or blockages in those arteries that take blood to the heart muscle can cause it. Hypertension in and of itself can cause it.
So is that hypertension? Is that just you're jacked up all the time? You're tense?
No. Hypertension means the actual pressure inside your arteries is elevated, and there are a variety of reasons why that happens, but most of the time we call it essential hypertension, meaning, well, it's elevated, but we're not exactly sure why. But we do know that it can lead to an enlarged heart, even if you don't have blockages in your heart arteries.
Right.
And once the heart stretches out and enlarges, it predisposes the patient to having what we call arrhythmias. In other words, the heart can go into a rhythm where it doesn't successfully pump enough blood.
Right.
And when the heart's not successfully pumping enough blood, you pass out. And if it stays like that, without any CPR, without any medical intervention, you can die from that.
Okay, so what can we do to prevent it? Do we get pictures of our heart? What do we do?
Well, I think, as I mentioned earlier, prevention is most important. But in order to prevent, we first have to be aware.
Right.
So I think we need to spread awareness of the symptoms of cardiovascular disease and also spread awareness of the risk factors. So that means go see your doctor, have your blood pressure checked, have your cholesterol checked. Regularly.
Which is what, 6 months? Every 6 months?
Depends on
once
the
a
age
year?
group. If you're in your 20s, once every 3, maybe once even every 3 years, if everything looks good.
Right.
As you get up in age, then you're talking about, maybe once a year. So I think we need to spread awareness of these risk factors, especially in those patients who know they've had a family member have heart issues at a younger age.
Right. So we just need to stay on it. Keep seeing your doctor and ask him. And then if you can, find a great doctor like Dr. Allen who can actually take you on. Do you have personal clients or you just handle it when it gets to the point of, I got to fix you?
Oh, no, I'm an interventional cardiologist, which means I'm trained to do all the technical interventions, but I also have a large focus on prevention. So I see patients at St. Helena Cardiology, which is now called Adventist Heart Institute. I see patients in the office and see patients at the hospital.
You do? Okay, so there you go. You just got the word. You can look up Dr. Stuart Allen. He's up at St. Helena Hospital. He's the new big shot. I can call you that. It's me. It's a generalization. But you're the new guy.
I am the new guy, yes.
And you're the specialist.
I am.
All right. Well, thank you so much for being on the show today. I think it was very informative.
Great. Well, thanks for having me.
I think we've all learned a lot. And basically what I learned is, this is my buddy Jim. Well, he went from a big heart. It's worse things.
I've been everywhere, man, looking for someone.